technical partners were, on hand to provide support to all these countries that were identified as high burden and high impact countries. The strategic information was also aimed at helping to develop context-specific analysis that is underpinned by value for money, to identify challenges that may have been hindering progress to malaria control, and also to be able to develop appropriate responses to achieve impact. And this strategy was stratification. So I'm going to be talking about stratification and how Nigeria went ahead to take on that strategy and used it in the process for developing a malaria risk map for the country and also for intervention targeting. So what is stratification? Just by way of definition, malaria risk stratification is the classification of geographical areas into geographical areas or localities according to specific factors that determine receptivity and vulnerability to malaria transmission. So when we say receptivity, we're talking about, the factors that make a particular ecosystem to sustain malaria transmission over a period of time. So those factors that come to play, going from vectorial capacity to the vulnerability of the population in that area, to climatic conditions, and all those factors that come to play that help to promote malaria transmission in a place. That is what is called receptivity. And more broadly, malaria stratification is classifying geographical areas or localities according to their epidemiological, ecological, social, and economic determinants, solely for the purpose of guiding malaria interventions. And so again, when we talk about intervention stratification, then we are referring to putting a group of interventions together, proven interventions that are being proven to work, putting them together in a way that you are targeting them or tailoring them to a specific area with the aim of reducing the burden of malaria in that particular area along, the malaria elimination continuum. So why do we stratify? Why stratify? We know that in Nigeria, for instance, malaria is heterogeneous in the country. And so it's important to be able to identify, to be able to break the country into different risk areas, because malaria is not homogeneous. When you talk about the epidemiology in Nigeria right now, it's heterogeneous. So what that means is that we cannot continue to use, one blanket intervention everywhere, just using, one capsize fits all. We just do bed nets everywhere, or we do case management everywhere, or, So it's important that we stratify, because malaria's epidemiology has become heterogeneous. And then it's also important to identify high-risk areas, because once you are able to identify those areas which are high risk, then it becomes easy to target those areas with your interventions. And then that gives you quick wins, rather than doing everything everywhere and you are not really moving the dial. And then intervention tailoring also helps. I mean, we stratify also to be able to tailor intervention, as I've mentioned. You are able to put the best mix of interventions together. Once you know what the epidemiology, the ecology, and all the determinants of receptivity in an area is, you are then able to put your intervention together to target, that particular area with all the tools that are required to achieve reduction in malaria in that area. And then the last reason why we stratify is for efficient prioritization. We know that resources are limited, especially now that, you know, in the fiscal space around the world, in the development world, we all know how tight it is right now, and it's not getting better. And so countries must be able to not only identify the strategy they want to implement, but they also must be able to prioritize the important ones within the resource envelope that is available to them. So countries should be able to determine what is the best mix of intervention that will give me the highest impact and at the cheapest price. So this is what we call prioritization and efficient allocation of resources. So I want to give an example of Nigeria, how they used malaria stratification in the national strategic planning process that the 2021 to 2025 strategic plan is ending now, and the country is already also in the middle of, you know, a malaria program review as a prelude to developing a new strategic plan for the country. The new strategic plan for the country is expected to commence from 2026. But the country right now is in the middle of a program review. You're looking at how far they have gone and all that to be able to determine, you know, the new, the direction for the new strategy. But this was how they approached it when the HBHI initiative was launched and the current strategic plan was developed. So I'd like to just take us through, you know, that process. So when we talk about strategic planning, WHO recommends that when any country is thinking about the strategy for malaria control, there are a number of questions you would ask. You look at the population at risk. You look at the transmission determinants. And you look at what intervention do I want to deploy? Where do I want to deploy the intervention? When? Who will I target this intervention at? And how will the intervention be delivered? So these are all the things that are within the strategy. Okay, and then the country then sets objectives for itself. Okay, looking at where we were before as a background, you know, the country will assess, do an evaluation of where they are coming from. What have we achieved so far? Where are we right now? And then from where you are, you then want to project, where do I want to be in the next 3 to 5 years as a country? And those are the objectives that are set, you know, for the country. And then where stratification and intervention targeting comes in, then is, okay, if I want to move from zero, if I want to move from, for instance, 35% of malaria prevalence, I want to move from 35 to 20% over the next 5 years. The question is, what do I need to do to get myself there? And where do I need to target my intervention? Where is the highest risk? Where in the country, you know, is the people most at risk of malaria, and where is the burden highest? And what do I need to do in those areas to drive down the burden? So malaria stratification then comes in there, where you look at your transmission determinants to determine what the epidemiology looks like and stratify the country into, you know, risk zones. And then once you have done that, you then ask yourself another question. What is the impact that I want to achieve from deploying these interventions in these areas? And this is where modeling comes in. And since I'm speaking to a modeling group this afternoon, where modeling comes in is where you then want to, stratification also, it's, you use modeling to do that, but you also need modeling to be able to predict your impact. So if I deploy 2 million bed nets in this area, for instance, and I add IRS to that, and I do case management also in that area, what is the likely impact I'm likely to have over the next 5 years in that area? And so that is modeled. And the country is then able to look at different scenarios to arrive at what objective or what target to set for the country. And then once the interventions have been determined, the optimum intervention that is needed to achieve the goal or the objective that the country is setting, then the next question is, how much does it cost me? How much is it going to cost the country to achieve these targets? And that is costing the NMSP. Now, once you have costed and you have a big value, I remember when the NMSP was costed in those days, it ran into several billions of dollars. And then we then ask ourselves another question: how much do we have available? And how much can we afford? And so based on how much we can afford, we then ask ourselves, how much can I achieve? How much impact, or what is the maximum level of impact that I can achieve with this available resource? And that is prioritization. This is where prioritization then comes in. Once you have your pool of intervention, and then you have a huge amount of money that is going to cost you, then you ask yourself, we don't have so much money. We only have this little envelope. So with this little envelope, how much can we take on? And this is where prioritization comes in the process for MSP development. And so the country went ahead to do a risk mapping. And just to take us through quickly, some of the considerations that went into the epidemiological stratification at that time. So first thing was that they took the crude incidence, that's looking at routine data and looking at malaria, the crude malaria incidence, just looking at found cases. And then that was then adjusted for testing rates, just to be sure that what you're looking at is not just clinical fevers. So it was adjusted for testing rates and then further adjusted for reporting rates, because whatever you pick from the HMIS, it does not necessarily reflect the entire country, because it is not all health facilities that are reporting in the country. So reporting rate was also adjusted for. And then care seeking behavior was also adjusted for. The proportion of people who will go to private sector, the proportion of people who will go to public sector to seek help, to seek healthcare, and then also looking at testing rates in those different sectors. So all that was adjusted for, and you see the final map that they came up with on malaria incidents. Starting from, you can see that as all those indices were being adjusted for, the map was becoming darker and darker. And then the second parameter that was used is malaria prevalence. And you can see the malaria prevalence in the country from 2000 to 2005 to 2010 to 2015 to 2018. This was the latest data that was available at that time. And you can see what the map looks like here. This is just a enlarged version of the 2018 map. And then all cause under 5 mortality was also considered as a parameter. And in 2000, you can see all cause under 5 mortality, that the entire country was red. And so this is just to show that it's not also gloomy. Between 2000 and 2017, you can see that some progress have been made. It's not all red any longer. And so this map was then combined with all these parameters were then combined. So malaria incidence was layered on malaria prevalence, and this was the risk map that emanated from that. And then under 5 mortality rate was also layered on that to give us the final malaria risk map for Nigeria, which is what you see on this side, that then shows the strata, you know, and tells us where the malaria risk is highest, very high, medium, and lowest. And you can see what the map shows us. So now just taking a closer look at how intervention tailoring was then done using SMC as an example. So we know that WHO recommends that SMC should be implemented in areas of highly seasonal malaria transmission, with 60% of all the clinical malaria cases occurring within 4 months of transmission. And where clinical attack rate of malaria is greater than 0.1 attacks per transmission season in that target age group. And also sulfadoxine, pyrimethamine, and amodiaquine, that is the medication that is used for seasonal malaria chemoprevention, must still be efficacious, more than 90% efficacious in those settings. So all these parameters must be assessed and they must be present before you can introduce seasonal malaria chemoprevention in that area. And so to determine the areas where Nigeria would be introducing SMC, these were all the parameters that were considered. And this map just shows rainfall seasonality, in Nigeria, that areas where you have more than 60% of the rainfall occurring within 4 consecutive months. That's what you have here. And when that was then combined with areas where malaria prevalence in children 2 to 10 years is more than 5%, as at that time in 2018, this is the picture that, you know, this is the map that was produced based on these parameters. So before, just to mention that prior to this stratification exercise, Nigeria was already implementing SMC, but it was just implementing it in states that were designated as Sahelian states in the country, and that was just 9 states in the country. However, you can see the beauty of stratification, because, I mean, once stratification was then introduced, we realized that actually there are more eligible areas, more eligible children for SMC than what we were implementing before. So before the stratification, only 9 states were deemed eligible for seasonal malaria chemoprevention because they were situated in the Sahelian part of the country. But once all these data were pulled into the process and the mapping was done again, the second map you see here is what then resulted. And so as we speak, more than 21 states in the country are eligible for seasonal malaria chemoprevention and are implementing seasonal malaria chemoprevention. So again, just to go through the thought process that went into, you know, these SMC intervention mix and the prioritization. So they looked at transmission seasonality. I talked about that. Wherever you have more than 60% of clinical malaria cases occurring within a maximum of 4 months, those areas were mapped out. And then combined with transmission level of more than 5% malaria parasite prevalence, and then also the fact that SMC drugs must be efficacious in that area. And then all this, you know, combined with early line targeted areas, because WHO also recommends that in any area where malaria transmission is ongoing, malaria vector control measure must be in place. A malaria vector control measure must be in place in that area. And in Nigeria, ITNs is the major vector control intervention that Nigeria deploys. So where ITNs are deployed, and that area is also eligible for SMC, the two interventions are layered on. And then that then leads to higher burden of disease. I mean, you can see, sorry? Okay. And then in terms of resource prioritization for SMC, because this could not be implemented everywhere, there was a need to also look at other parameters to prioritize the areas where these interventions would be deployed. So areas where you have lower access to case management and lower access to vector control intervention, those areas were prioritized for this intervention. So I'm rounding off now. So at the end of the stratification exercise, those areas that were identified as, the malaria risk map, as the areas that were identified as high.
Sorry, hold on, ma.
Yes.
Hold on, we have a problem.
Oh, okay.
Just few minutes, ma. We have a power. Just few minutes. Just power outage, ma. Few minutes, ma. Ma, we are back, ma. Sorry for the break in transmission. Thank you, ma. Go ahead, ma. Ma, unmute yourself, ma. You are muted, ma. Unmute yourself, ma.
Okay, can you confirm you can see my slides?
Yes, ma. Yes, ma. We can.
Okay,
we can.
All right, thank you. Right, so I was talking about the the mix of interventions. And I did explain that following the malaria risk map development, intervention mixes were then determined based on the malaria risk that were mapped out on in the malaria risk map. So you can see on this slide, you have the mix of interventions that were determined for the different areas in the country. And as you recall that I mentioned earlier that the epidemiology of malaria in Nigeria has evolved. It is no longer one size fits all. So there is a need to look at the different areas in the country based on the the malaria risk in that area and all the context, and then tailor interventions. So you see that in the area where you have blue, generally across the entire country, case management is an intervention that is deployed, which means anyone who comes down with fever should be tested and treated with an ACT. Intermittent preventive treatment in pregnancy is also across board, everywhere, because pregnant women are everywhere and they are the most vulnerable, they are at risk, so they must be protected. Bed net use is also everywhere. However, the mode of delivery of the bed nets is not the same across board, and the type of bed nets that is distributed in the different areas is also not the same. And this, we were able to come to because of stratification. We were able to determine which area will need PBO nets. PBO nets is only deployed in areas where you have malaria resistance that is based on, biological or chemical mutations, chemical changes in the in the vector. So if you have a different means or a different type of resistance happening in a particular area, you cannot deploy the same type of net in that area. So even though bed nets is still recommended everywhere, the mode of delivery is not the same. There is also the prioritization of campaign of nets, mass campaign of nets, which means that in urban areas where malaria risk is usually low, those areas are deprioritized for mass campaign. Other channels of delivery of nets will be used in those areas to distribute bed nets in those areas. And then, as you can see, that seasonal malaria chemo prevention is recommended in the northern part of the country mostly. And then intermittent preventive treatment in infants, which is now called perennial malaria chemo prevention, is recommended in the lower parts of the country. So wherever you have SMC happening, PMC is not happening there. PMC is happening in the southern part of the country. So this is what the intervention mixes look like. So in conclusion, malaria stratification is a key pillar in the rollback malaria high burden, high impact initiative, and Nigeria has demonstrated its usefulness in malaria risk mapping and also in intervention tailoring. And this has been very useful for the country because that has then helped Nigeria to target interventions and also to be able to, focus more on the areas where malaria risk is highest. So I thank you for listening. And thank you for the opportunity. Hello. Hello, I'm done. Hello?
Are you here?
Yes, I can hear you now.
All right. Okay. So thank you very much for the presentation. Very insightful. And we're seeing how Nigeria, we're beginning to respond to the malaria burden we have, especially with the high risk geospatial.
Hello, sorry, I can no longer hear if anyone is speaking. I can't hear. Hello. Sorry, I can't hear. I can't hear you.
A mathematical modeler. How do you assess your organization to obtain data, reliable data for model prediction? Secondly, how do I partner with you and control of modeling in my area?
Okay. All right.
Right.
If I heard you correctly, is that a question for me? Hello? Can you hear
Yes.
me? Okay. All right. Thank you very much. So Malaria Consortium works very closely with the National Malaria Elimination Program. And the data that we generate actually is national data, and it flows into the National Malaria Data Repository. So if you need any kind of data whatsoever, all the data for the country on malaria is domiciled with the National Malaria Elimination Program. And we can certainly connect you with them to if you need the data. So that should not be a problem at all. I hope you heard me.
Intervention data. Because those of us that are into optimization, how to optimize vaccine performance and the rest, we are hearing as a consequence of this conference that our optimal controls don't answer real life problems anymore. So because we vary data and we just say forecast and we just tell the public health to do this at this rate. Now we are constrained. Is there my question now is, do we have data for intervention? Say if you like LLN use and so on, do we have data for them per state like we do have for cases of malaria? Those interventions Nigeria have used so far, do we have data for them that we can consult? Thank you so much.
Thank you.
Okay, so when you talk about ITNU's rate. That is a survey data. It's not a routine data. So, and if you want survey data, that is not something that is generated routinely. It happens periodically. And in Nigeria, the Malaria Indicator Survey is a national survey that looks at all the intervention coverages across the country, going from ITNUs to IPTP to even case management and everything you can think of. And that happens every 3 years. And that data is publicly available. The NDHS is also, a source of data for that kind of intervention coverage. However, this last NDHS that was carried out, Nigeria missed the opportunity to include malariametric component in that NDHS, and we couldn't do that. But the country is planning to do a standalone malaria indicator survey on their own this year, because they expect that will feed into the malaria strategy planning going forward. So routine data is available, like I said earlier, is available with the National Malaria Elimination Program. They have a National Malaria Data Repository. What you need to do is just to make a request and specify the kind of data you need, and that can be made available to you. But then when you're looking at intervention coverage, net use, and all that, those are survey data that, are also already in, for the ones that have been carried out already. They are in the public space, and you can find them on NGHS and NPC.
Thank you very much, Dr. Olushola. We're very grateful for this time. We also want to say that we have been well informed by the presentation you have made, and several of us, just as you have advised, will start now looking at how to work with Malaria Consortium so that the solution we are trusting for in our land and the different communities that makes up Nigeria can be achieved. We really want to appreciate you. Thank you very much for your time.
Thank you so much for having me. Thank you.
Well, okay. No, you do it. Wait. We're going to be going to take a meal now, but just before that, when we're coming back, we're going to enter into the technical session where there will be presentations and it will be in groups. I know those of us who are presenting our papers have already been told the group we belong to, and if you have not actually been told, please, you need to meet Dr. Afis so that you can choose. I mean, you'll be told the group you belong to. But then, Mr. Olashupo needs to quickly do 1 or 2 arrangements in order to know where you'll be staying when we return.
All right, thank you so much for staying true. And we know that you have been very patient. It's a long day. So now we want a situation where when you are returning, you return to the location of where you'll be participating in the conference. We will not all be here because the presentations will be holding in parallel. So for that, you need to know where you would be going to. For that, we have 4 groups. And so please, Icammda team and the price team, can you help me? You just give people number 1 to 4. If you are a presenter, you have already taken a number, so we don't have to take any number again. So once they get you, just say, I'm a presenter. So, and we'll move to the next person. So please, can we give number 1 to 4? And then you can also exclude the professors. So we will have to split our professors across all groups. Can we start now? Please let's start the numbering. Just give 1 to 4. And once somebody indicates to be a presenter, skip the person. Also skip our professors, please, because we want to spread them across all the groups. Don't forget to indicate if you are a presenter so that you will not necessarily be giving another number. I'm not having anybody giving them number here. Three. We'll talk about it. All right, are we done in this place? Are we done here?